So again, so good afternoon to all of you. So our learning objectives for this afternoon are still drugs related to pregnancy and lactation. However, in our previous discussion, we have covered some of the drugs that are covered in situations like minor discomforts during pregnancy, and we have also covered the drugs that may control the preterm labor, which are called as tocolytics. Now, we have situations that pregnant mothers are experiencing hypertensions. So, hypertensions, they are not known hypertensive, but they experience hypertension only during pregnancy. So, if we are considering elevated blood pressure without proteinuria, so what do we mean by that? The proteinuria is the presence of protein in the urine. So, if it is without the proteinuria and the period is 20 gestational weeks. So, if we're considering 20 gestational weeks, so that's almost how many months na iyan? Almost
Four po.
yeah, correct. That's almost 3 to 4. Okay, 4 months. So for that period of 4 months, if the patient is experiencing hypertension, kasi if we are considering hypertension, actually now 120 over 80 is not anymore normal eh. The normal blood pressure is below 120 over 80. So it means that 199 systolic and 79 below of the diastolic are considered normal. If one actually 120 over 80 according to Joint National Commissioner JNC 7 on the classification of hypertension, 120 over 80 is already pre-hypertension. Pre-hypertension. And and if for example a pregnant mother experiences elevated blood pressure without proteinuria, because usually pregnant mothers are subject for urinalysis, and if there are elevation of blood pressure and no uh, indications of presence of protein in the urine at the age or at the period of 4 months or 20 gestational weeks, that's what we call gestational hypertension. Actually, we are not anymore using we are using actually gestational hypertension. Before the term that is being used on hypertension during pregnancy is pregnancy induced hypertension. So from the term itself, the the hypertension is induced, brought about by the condition of pregnancy, but it is not anymore used nowadays. Moreover, it uses na gestational hypertension. Now sir, how about if the pregnancy has already proteinuria? Okay. So if it is without proteinuria, it is gestational hypertension. If it is with proteinuria, the term that we will use is pre-eclampsia. Okay? So usually we are considering 10 to 20% reported based from statistics that almost 10 to 20% of the pregnant population are considered with hypertensive disorders. And for preeclampsia, usually the incidences is usually 5% to 8% of all pregnancies are with preeclampsia. So again, emphasize the difference. Elevated blood pressure without proteinuria is gestational hypertension. Elevated blood pressure with proteinuria is preeclampsia. Now, what is mainly the concern with proteinuria? Actually, we all know that uh, in urine analysis, there must be no findings of protein. Why? Because the protein are are are, are circulating throughout the body, which will help okay, which will basically help in our tissues. Now, if actually we are aware that the blood pressure is being regulated by the kidneys, then if there are situations that there is if there is a problem with the excretion of protein via urine, it means that the kidney is not capable of managing and stabilizing blood pressure. So, sir, which is worse? So obviously the one that has the proteinuria, because there could be instances that when we call preeclampsia, usually these are situations that somehow may not control. And gestational hypertension, since it doesn't have any proteinuria, it means that the kidneys or our kidneys is still in control in sustaining the blood pressure, but even higher than normal. Now, let us differentiate gestational hypertension from preeclampsia to eclampsia. If if the preeclampsia leads to other manifestation or additional manifestations of seizure, so it means that the hypertension itself affects the central nervous system, and specifically the nerves, obviously. This may have a possibility of seizure, and that's a condition by which really it must attend as an emergency situation. So let us now differentiate what is preeclampsia and what are eclampsia. Okay, there are two categories. So the two categories, so we have preeclampsia and the eclampsia. So the basic difference between mild and severe preeclampsia is based from the blood pressure, from the systole and diastole. Okay, so if the blood pressure increased to above 140 systole, above 90 diastole, but below 160. Okay? Below 160. So ibig sabihin, above 140, above 190, but below 160 systole, and usually happening two times at least 4 to 6 hours apart within a week. So these episodes of more than 140 and more than 90 diastolic but less than 160, and usually happening twice and 4 to 6 hours interval a week, that's already mild preeclampsia. Now, what is the severe preeclampsia? The severe preeclampsia is above 160 over 110. So it means that there are twice or two occasions, almost almost 6 hours apart, while the patient is on bed or at rest. So one of the bases is blood pressure. More than 140 systole but less than 160, more than 90 diastole, and happening twice at least 4 to 6 hours within 1 week. So that is already mild preeclampsia. So once the patient had already recorded this blood pressure, continuous monitoring is very significant. Now, if the severe goes with the above 160 over 110, and again twice and 6 hours apart, but the patient is at rest, that's already severe preeclampsia. When is the time that the pregnant client goes with situations of the what we call eclampsia? It's either mild or severe. For example, if the mild preeclampsia has already episode of grand mal seizure, the seizure itself, that's already classified as eclampsia. So, for example, the blood pressure is above 140 systole, above 90 diastole, but less than 160, and then it comes to an episode of one grand mal seizure or grand seizure, okay, the patient may have the seizure, then it may not be anymore mild preeclampsia, but it's already eclampsia. So if whether mild or severe, if there are already signs of seizure, that is already eclampsia. And once the patient may have seizure, there could be possibility that it may affect also the fetal well-being very seriously. And this must be prevented. So what are those drugs that may be given for gestational hypertension? Okay. Now, usually episodes like if the patient has already severe preeclampsia. So meaning the patient is still not having, okay, still not having seizure. So again, our basis of the blood pressure for severe preeclampsia is above 160 over 110 twice 6 hours apart in a week. Usually, the the drug of choice. However, this is even though this is the drug of choice for severe hindi naman drug of choice kasi hindi pa rin natin mai-consider na drug of choice kasi category D. If you can still remember again the FDA pregnancy risk categories. So category A has sufficient studies to be safe for both mother and the fetus. For the category B, it is it has no risk, no evidence of risk for mother and the fetus, but no sufficient studies. For category C, animal reproduction study shows that there are possible adverse reactions for fetus, but no evidence for the mother. For the category D, obviously, there are already positive studies that may significantly affect both mother and the fetus. Now, in this situation, we have category D of magnesium sulfate. So there is a possibility of risk of it will affect both mother, positive adverse reactions for both mother and the fetus. Now, the drug is called as magnesium sulfate. Now, I even mentioned this to you that even before that the magnesium sulfate must be checked. Okay, it must be checked uh, first and primarily for deep tendon reflexes because you will withhold the drug if there are no response for deep tendon reflexes because chances that it may lead to paralysis. Now, sir, why isn't it that the uses is prevention and treatment of seizure related to preeclampsia? As what I have told you, 'di ba pagka severe preeclampsia, once there will be a seizure, it's already eclampsia. Okay. How and to what extent that the fetal well-being could be high risk? Remember class, any hypertension, it will always involve blood vessel. And once there will be in elevated blood pressure, most of the blood vessels are leading to pressure and leading to constriction. And once it leads to constriction, it may delay the possibility of the maternal blood flow and may significantly affect fetal circulation. So eventually, the fetus could be uh, deprived from the oxygen supply. So that's why if the patient already experienced seizure, then this is a scenario that is considered as eclampsia because it's already affecting the central nervous system. So the point of having magnesium sulfate to a patient who has severe preeclampsia is prevention. Now, this is contraindicated with myasthenia gravis. So I have mentioned to you that myasthenia gravis is a specific disorder affecting the myelin sheath of the blood of the nerves rather. So usually, the action of magnesium sulfate is to decrease acetylcholine. So we are familiar when it comes to the acetylcholine, this is related to the what we call parasympathetic response. Now, since most of the effect of the magnesium sulfate is more on the parasympathetic nervous system, I just want to ask and have a review in parasympathetic response, normal, what is the effect to the bronchi? Is it constriction or dilate? Constriction. Yes? Constriction. Okay. How about for the heart rate for parasympathetic response? Is it increase or decrease?
Decrease.
Decrease po.
Decrease po.
Increase or decrease?
Decrease.
Parasympathetic. Decrease. Okay, very
Decrease
good.
po.
Now, if this drug concerns with parasympathetic response, class, if ever that the client will experience magnesium sulfate toxicity, you always take into consideration the antidote. And the antidote that will counteract the adverse reactions of magnesium sulfate, if it is on a toxic level, it's calcium gluconate. Always have on the bedside or in the emergency cart, when you give magnesium sulfate, always have calcium gluconate. Actually, calcium gluconate, this is not recommended 2 hours prior to delivery. If ever, for example, 2 hours prior to delivery, the client is having severe preeclampsia. Remember, class, that if calcium gluconate may be given 2 hours prior to delivery, what will be the effect? The effect is it may lead to immediate response for parasympathetic. So that may affect significantly the bronchial constriction, and it may cause an effect pertaining to cardiac suppression. It means it will lower the heart rate. So somehow, the mother could be high risk of maternal respiratory depression. Plus, always take into consideration that when the patient has below 10 breaths per minute, you must refer it to the physician and stand by the antidote calcium gluconate. Now, if you have given magnesium sulfate, however, if the client, this is now the concern, sir, you have mentioned that calcium gluconate may not be given 2 hours prior to delivery. If the client has still severe preeclampsia 2 hours prior to delivery, that is the patient will be subject for emergency cesarean section. Because of the chances that if magnesium sulfate will still be given 2 hours prior to delivery, the patient could be high risk for what? Could be high risk for the maternal depression and cardiac arrest. To what extent? Because class, if ever the client will be subject for the normal delivery, then eventually continuous severe preeclampsia is happening, it means it may compromise the situation of the fetus when it comes to circulation. So if the fetus will be deprived intrauterine life of oxygen, it may lead to fetal distress and pwedeng mag-fetal demise. The fetus will have its death inside the uterus. So to prevent that, better subject the client to cesarean section rather than give magnesium sulfate because of the risk that it may lead to maternal respiratory depression or cardiac arrest. Any questions so far? So take this when you will be assigned in delivery rooms and handling clients in labor with severe preeclampsia. Next, Other than the magnesium sulfate, other drugs that we may give could be possibly hydralazine hydrochloride. Okay. We all know that during hypertension, our problem is the pressure created within the blood vessel. So what would be the drug that may support to counteract this constriction or pressure in the blood vessel? So it could be hydralazine hydrochloride, which is a vasodilator. Now, usually, the one that is being dilated by the hydralazine hydrochloride is the arteries. Now, this is to control the diastolic pressure of patient with severe preeclampsia of 90 to 110, at least 90 to 110. That's our focus. Now, if for example, the client is preeclamptic, then the client may have continuously have diastolic of more than 105 millimeters mercury. Oh sir, you have mentioned that the purpose of hydralazine is to maintain diastolic 90 to at least acceptable of 110 millimeters mercury. But the point, if this is another rule that you need to consider in giving hydralazine. If the diastolic pressure is consistently more than 105 millimeters mercury, continuous monitoring every 30 minutes and every hour, then you will withhold hydralazine hydrochloride. Okay? Because of the chances that the drug itself is not acting to its indicated purpose. So probably it may change to another drug. So that's why it's category C. So meaning the hydralazine hydrochloride may cause a possible adverse reaction to the fetus. Methyl dopa. Methyl dopa is category B. Now, what is category B? It is safe with the mother and the fetus. However, the concern is pertaining to a concern na there is no sufficient studies, there are no sufficient research findings that will support of, of a problem or a concern with the risk for both mother and child. So that's why we need to have extra uh, we need to be very cautious in giving this drug. Although the purpose of methyl dopa is to stimulate the central adrenergic receptor. So what we meant by central adrenergic receptors, if we say central adrenergic receptors, this will transmit the signal directly to the heart. Okay, directly to the heart, so that it will facilitate the stabilized contraction of the heart and prevent hypertension. However, we need to take into consideration a caution because sedation is usually transient. So we need to take into consideration if the client is experiencing drowsiness. So that's why it's very important for all of us that I am discussing these drugs, because you will encounter this when you give a drug and observe some problems with drowsiness, then withhold the drug and refer it to the doctor. So just the same as with the hydralazine, that although you are oriented to consider the maintaining the diastolic, the diastolic of 90 to 110, but eventually if it's more than 105 millimeters mercury continuously, consecutively, then withhold the drug. Okay, so any question from the first three of the drugs? So we have discussed the magnesium sulfate, but you need to monitor the deep tendon reflexes. However, we need to take into consideration some of the precautions as mentioned with the magnesium sulfate, that it is not given 2 hours prior to delivery because of risk of maternal respiratory depression and cardiac arrest. Methyl dopa, could lead to dilation of the arteries to maintain 90 to 110, but continuously the blood pressure specifically diastolic pressure is more than 105 millimeters mercury, will withhold the drug. Methyl-dopa. Methyl-dopa, it will improve the outflow. It will improve the response of the heart pertaining to the maintaining to sustain and stabilize blood pressure. However, we need to be cautioned if the client has, since it has the sedative, okay, sedative effect, it must take into precaution if the client is experiencing drowsiness. So next slide. Now, familiar with labetalol. So all drugs that are ending in lol. Okay. Those drugs ending in lol are basically related to beta blockers. It blocks the beta 1 receptor. And the beta 1 receptor is the one that transmit impulses to the heart to increase contraction. However, for severe preeclampsia, labetalol is prescribed if there are already chances that the client is experiencing palpitations or too much forceful contraction of the heart. Palpitations, plus you may feel the increase in the forceful contraction of the heart. You can still feel it. You may feel it if there is palpitation. So that's why beta blockers could be one. However, you need to monitor adverse effects. The adverse effects are orthostatic hypotension. So if we say hypotension, there is a sudden drop of blood pressure if change in position. If the client changes position and there is sudden decrease in the blood pressure, then withhold the drug. If there is dizziness, dizziness is different from drowsiness, because if there will be dizziness, actually, that's an indication of most considered deprived oxygenation to the brain. So withhold the drug. So I will accommodate, I think there is a question. Sir, bakit po ulit di dapat ibigay yung hydralazine? Okay. Bakit po hindi pwede o hindi po ulit dapat ibigay ang hydralazine sa patient with diastolic 105 millimeters mercury? Okay, ganito. Actually, di ba, the range of the hydralazine is at least to sustain 105 to 110 millimeters mercury. If you have noticed and observed that the systolic blood pressure is already consistent, okay, already consistent of 105 and up in few hours, in hours, in succeeding hours or consecutive hours, you may withhold the drug on situations like hydralazine may not be effective anymore to support and sustain the blood pressure. Kasi there could be a possibility, kasi severe preeclampsia siya, at once mag-lead yan into the possibility of continuous increase in the blood pressure, kasi nagpe-pre-ano na siya eh. So preeclampsia na siya. From the term preeclampsia, anytime the client may lead to eclampsia. And what is one of the manifestations to say that the client is already reaching eclampsia? The client is yes, very good. If the client is already having grand mal seizure or seizure. So that's why we need to discontinue the drug, because eventually it must be changed to a drug that will support prevention of the seizure or prevention of the what we call eclampsia. So that's why possibly the client may have already magnesium sulfate. So they may withhold the hydralazine, the client may have the magnesium sulfate, because that's an indicative that consistent 105 and up of the diastolic pressure could possibly lead to a seizure brought about by hypertension. Okay, so hoping I answered the question. So before I proceed with the next slide, are there any question on the first 4 drugs that we have discussed? We have the magnesium sulfate, which the antidote Okay. What's the antidote again of magnesium sulfate if it reaches its toxic level?
Calcium gluconate.
Calcium gluconate. Very good. So again, one question. Yeah, it's already answered. Thank you. So next is we have the calcium gluconate. And what are the two? Why is it that we will not give the drug? We will not give the drug 2 hours prior to delivery. What are the two situations that the client may experience?
Maternal depression and cardiac arrest.
Very good. Thank you, Mr. Gong. So the client may have maternal respiratory depression and the other one is the client may have cardiac arrest. Question ngayon, sir. O yan. So thank you for addressing that, those chances. Sir, how about if during the time that the client may have magnesium sulfate, then it reached already that the client is having respiratory suppression. What will be the antidote that may help to increase prevent yung respiratory depression? Kasi as seemingly the nurse observed that it's consistently 10 breaths per minute. So pwedeng mag-lead yan from depression to respiratory arrest. So what could be the antidote of that of the effect of the drug, of the adverse reaction of the drug because of that situation of respiratory depression? Class, remember, if there are respiratory depression or suppression brought about by the drug, which is an adverse reaction, you may have naloxone hydrochloride. Again, if this is also given to babies or newborns, where it identifies respiratory suppression or depression, you need to stand by an emergency drug such as naloxone hydrochloride for respiratory suppression if it did not anymore prevented. Next, sir, paano naman if the magnesium sulfate reach already the point of cardiac arrest? So syempre, aside from the cardiopulmonary resuscitation, you must have a standby what you call this adrenergic drug to support and increase the heart contraction. So what could be the drug? The drug that may counteract cardiac arrest is epinephrine, a drug which is an adrenergic drug that may increase heart rate. So again, if ever the client may have maternal respiratory depression, the client may be given with naloxone hydrochloride. If the client experiences cardiac arrest brought about by the drug of magnesium sulfate, then have epinephrine. Now, what will be your responsibility? All of these antidotes that I am mentioning to all of you must be standby whenever the client is already experiencing preeclampsia or eclampsia. So that's why you are treating the patient with magnesium sulfate. At the same time, you are preparing yourselves if ever there will be manifestations of adverse reactions of magnesium sulfate. So have the standby calcium gluconate, have a standby naloxone hydrochloride if ever there will be maternal respiratory depression, and have a standby epinephrine if ever there will be cardiac suppression or possibly cardiac arrest. So thank you very much. So are there any questions from the first four? Oh, now another question. This usually appears in the board exam. When the client had been administered with labetalol, so beta blocker siya, then the nurse monitors the client's heart rate and pulse rate and revealed below 60 beats per minute. Will you withhold the drug or will still administer the drug as prescribed by the doctor? Answer.
Withhold po.
Okay, so why withhold the drug? Because the drug itself may further suppress the cardiac response because it's beta blocker. You block the beta receptor that will increase the heart rate, and yet you will still give a drug that will suppress the cardiac response. So you will withhold the drug and refer it to the physician for any drugs that may be changed or possibly this drug may be discontinued. So those are the aspects that even I may not emphasize it on our discussions, but once you will use your critical thinking and analytical thinking whenever encountered questions in the board exam. Okay, so next, now let us now proceed. Let us now proceed to pain control. As what I have told you, that pain management is usually encountered when there is progressive phases of labor, because as the labor progresses, the pain also increase its severity and the contraction becomes regular. So there must be a non-pharmacological management to manage labor, and there must be pharmacological management if it is already not tolerated by the mother. But it's not usually advisable to manage the pain using opioid and narcotic analgesics. Because why? Because as what I have mentioned to you, yung mga opioid, yung mga DON, yung mga narcotic analgesics may have significant direct effect to the central nervous system of the mother, which may cause a possible drowsiness that may also had an effect to the fetus. So as much as possible, if it's kasi may mga, there are some situations I've been assigned in the labor that the client cannot anymore tolerate the pain. But usually these are situations like you can compare how a multipara mother is in labor, and the other one is yung para gravida, yung first time pa lang yung first time pa lang na nag-labor. You will observe the difference eh. The difference is usually the first time na nag-labor ang mother, usually and sometimes exaggeratedly, the minor pain, they may perceive it already as severe pain. Compared to a mother who have already have the multiple deliveries because she knew specific phases of labor. Now, the nurse must be knowledgeable on how to know specifically that the pain is already at its peak and cannot be tolerated. Kasi the pain itself, if there is a strong contraction, the pain is severe. And if the pain is severe and there is strong contractions, and it is usually on a regular time interval, the baby intrauterine is also affected. But here comes the point. When there will be a strong pain and a strong uterine contractions, what you will do is it will check the internal. Okay, you will do internal examination. Dapat, if there will be a strong uterine contractions, the effacement or the opening of the cervix must be also simultaneously increasing its opening. But there are some instances like this. The labor goes progressive, it increases the severity, the contractions are already regular every 2 minutes, but the cervix is not opening. Plus, if that happens, usually the client could be subject to cesarean section. Because why? To what extent? There is already an increasing intrauterine pressure, and yet the cervix is not opening. So there is something wrong with that, because once it will continue the regularity of the contraction of the uterine muscles, it will also create pressure and fetal distress. So chances again, it may cause the possibility of risk to the fetus. So that's why sometimes on those situations, it may subject the client to cesarean section. However, it's not always to take into consideration, okay, I decide at the time na I chose to have cesarean section rather than normal spontaneous delivery. Remember, NSBD, normal spontaneous vaginal delivery, still is the normal delivery. Okay, vaginal siya. Because physiologically, the body or the body response or the physiologic response of the mother is having a normal delivery. The cesarean sections are those situations wherein it will risk the baby and it will risk the mother. That's why the client will be subject for cesarean sections. Now, pertaining to pain control, we have the three terms that we have terms that we may encounter. Actually, we have three terms. We have analgesia, we have sedation, and we have anesthesia. Okay. So what are the difference of the three? If analgesia, obviously I know for a fact that all of you have received analgesics from paracetamol to mefenamic acid. Uh, did you experience any loss of consciousness or drowsiness upon receiving paracetamol? Di ba no? No observations on that?
No.
Because the pain relief doesn't have direct effect on the pain receptor, specifically directly on the central nervous system and the pain receptors that regulates in the brain and the nerves. So there's no effect on that if it's not direct, unlike for unless this, although ginagamit unless and except if the analgesia is opioid or narcotic analgesic, it may not still cause loss of consciousness, but still there could be pain relief, but there will be drowsiness. Okay? Pero usually, when we say analgesia and insensibility to pain without loss of consciousness, the client is still conscious. The client can still identify and alert, can still identify what is happening around, and the client is on the state of alertness to be for him or for her to be aware of what is happening in her environment. Now, what is sedation? Okay. Analgesia may cause drowsiness. Pag sedation, the sedation is it will diminish mental and physical responsiveness. What does it mean? Do you know the colloquial term droge? Okay, yung pag nadodroge, ibig sabihin yung state mo, inaantok ka, and sometimes you feel heaviness sa katawan mo. Pero you're still aware, okay? You are still aware of what is happening around. Kasi ano lang you are experiencing a higher level of drowsiness, of mental diminished mental response, tapos yung physical din. So yon, sedation. So please sedate the client. Usually sedation are given if talagang it cannot be tolerated by analgesia, and if we talk about sedation again, it usually sedation are given pag if the labor pain is not anymore tolerable, if it is close to delivery. Why? Kasi somehow if it is close to fully dilated at any time it goes to delivery, hindi na yan makaka-reach sa fetal circulation and may significantly affect the fetal response. sa mother, makakatulong yon when it comes to pain management. Now, when it comes to anesthesia, ito talagang yung isa diminish use of diminish, and the difference sa anesthesia is loss of pain sensation. Di ba pag anesthesia, loss of pain sensation, there could be numbness, you may not feel any pain. This is either local or this is either general. Pag local anesthesia, we are referring to specific area, and for general anesthesia, we are referring to the whole body is having loss of painful sensations. Now, when we talk about spinal anesthesia, the loss of painful sensation is usually upper extremities. Okay? Upper extremities ang loss of sensation, but the lower extremities may still feel painful sensations. So these are the difference. Analgesic can still be insensible to there is insensibility to pain pero without loss of consciousness. Sa sedation, usually diminish ang mental and physical responsiveness. So there is pain management, but for anesthesia, there is loss of painful sensations with or without loss of consciousness. Example, kasi there are some situations like for general anesthesia, usually the pain experiences loss of consciousness and at the same time loss of painful sensations. But there are some situations that like spinal anesthesia. So sa spinal anesthesia is usually on this abdominal part down. Abdominal part down. So kung abdominal part down, from abdominal part up, the patient is still can still move the upper extremities, but yung lower extremities niya, it cannot be moved while having the spinal anesthesia. So that's why it indicated there with or without loss of consciousness. So can you now differentiate what are analgesia, sedation, and anesthesia? So we'll just accommodate a question. Din, pwede po ba elaborate ang difference ng sedation or anesthesia? Okay, sa situation. Okay, situation like the client will have normal spontaneous vaginal delivery. So normal delivery. So sa normal delivery, she is still aware of what is happening. Kaya pag the doctor will tell, madidiminish yung pain but not totally diminish, not totally. So partially madidiminish. May drowsiness ka, pero yung body mo din may limitations when it comes to responsiveness, pero you are aware what is happening. So bibigyan ka bago ka mag-deliver, i-sedate ka. Then when the doctor will tell you, okay, push. So the mother can still respond. Okay, pero diminish lang. Unlike for anesthesia, for example, ang anesthesia is loss of painful sensation with or without loss of consciousness. Example, did you hear about painless delivery? Did you hear about painless delivery? Yung painless delivery, si mother, mararamdaman pa rin niya yung contraction, pero once na-deliver niya yung baby, it's painless. Kasi that's the point wherein when the nurse will monitor the client, okay, it caused contraction. Tapos the mother will bear down, iire from a count of 10. 1, ire, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Class, the client can still do that kasi 'di ba nga ang kanyang response is it may loss of painful sensation only on the abdominal below, but still on the upper part the client can still respond. So ibig sabihin ito sa pagdating natin sa sedation, the difference is that of the client is conscious of what is happening, pero siya, inaantok siya, nababawasan yung pain receptor.
Kalmado po.
Yeah, mas kalmado siya. Pero still, pag nag-contract na yan, kailangan niyang mag-respond to the bearing down. Next, pag anesthesia naman, ang nurse ang mag-hint sa patient kasi hindi niya mararamdaman yung ano hindi niya mararamdaman na nagko-contract yung uterus So si nurse ang role niya, her role is okay mommy, there is already contraction, then bear down. 1 2 3 4 5 6 7 8 9 10. Tapos pag nawala na siya, relax. Pag nag-contract lang yan, dun pa lang mag-i-instruct si nurse na magbe-bear down. Unlike kung ikaw ay sedated lang, ayan na, 1, 2, 3, 4. Yun ang difference ng sedation dun sa anesthesia. Kasi pag painless delivery, si mother hindi niya mararamdaman yung severe contractions kasi nga painless So, ayan, alam mo naman patulugin mo lang yung mother. So medyo magre-relax pa yung si mother kasi hindi niya nararamdaman yung pain. Pero once mag-contract na yan. Mother, nagko-contract na. Bear down. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Ayun. So yun yung difference between sedation. Si mother, nakaka-identify pa siya ng pain, ng contraction pain, so that to bear down. Unlike for the anesthesia, there could be a difference dun sa pain na nararamdaman pag sedated lang, at pag anesthesia naman, the nurse must initiate to inform the mother and assist the mother to do the bearing down. The question is, why sir 1 to 10? Bakit kailangan mag-bear down si mother ng tuloy-tuloy na 1 to 10? And why only during contraction? Because pag nag-contract ang uterus, ibig sabihin, muscle contraction, pinupush niya si baby palabas. Once the baby is pinupush niyan palabas at nagbe-bear down siya, the cervix is also opening. So sabay siya na nag-open. Ngayon, can you imagine kung iire si mother, tuloy-tuloy na siya. 1, lalabas si baby, di ba? Kunyari si baby lalabas. 1, hindi kita. 1, 2, 3, 4, 5. Tapos bumawi si mother. Babalik. Will there be a possibility na maka-affect yan dito sa head ng baby? Yung 1, 2, 3, 4, tapos babalik. Di ba pag
Yes po.
yeah, kaya the more na nagko-contract pa yan, you need to have and maximize 1 to 10. Kasi pwedeng magkaroon niya ng what we call yung cone head, yung caput succedanum, yung cone head. Kaya minsan may mga instances na mahaba yung ulo. Pag na although babalik naman yun into normal, pero try to imagine na nagkakaroon ng pressure sa head ng newborn, tapos iire, tapos prematurely babalik, lalabas, babalik. Can you imagine that? Lalabas, babalik, nagke-create ng pressure sa head. So that's why there's a major role when it comes to this drugs. Kasi mommy, sedated ka lang alam mo, you as a nurse, mommy, alam mo, if nag-contract, ire ka 1, 2, 3, yan, ire. Si mommy, under anesthesia. So binigyan ng spinal anesthesia. So the point is, aware si nurse na the pain sensation is different from the one who is sedated. So binigyan ka ng anesthesia. So kung binigyan ka ng anesthesia, si nurse dapat mag-monitor if it already contract. Kaya sasabihin niya ng nurse, mami, nagko-contract, ire, bear down, 1, 2, 3, 4, 5, huwag mong bawiin, 6, huwag mong babawiin, 7, 8, 9, 10, until ma-deliver yon. So, class wala naman gumagamit siguro ng paracetamol lang sa panganganak. So ang analgesia, ay for mild labor pain lang, pero can you imagine na ang ginagamit mo lang for for delivery na or for the late phase ng labor ay ibuprofen, ay paracetamol. So never it will because ang sedation at ang anesthesia, yung mismong direct na sa pain receptor ang kinokontrol niya. Kaya somehow, kasi pag kinokontrol mo ang pain receptor at binablock mo, bumabagal din yung response ng mga cells on the electrical charges. Kaya somehow, may effect din talaga siya directly to the consciousness of the client. So, yeah, epidural. Okay, meron nag-address ng epidural. Yung epidural is somehow the same also with spinal. Okay, so sa spinal anesthesia and the epidural anesthesia, which is later I will discuss it. It's also a loss of sensation, just the same as for the spinal on the part of the extremity lang dito sa abdomen pababa. Okay, kaya somehow ang client mo when ambulation when ambulation after delivery, you are expecting the client na by 2 hours she cannot move lower extremities. Kaya what could be the role of the nurse kung hindi niya ma-move? Pwede bang it may affect ba the circulation of the lower extremities kung hindi na ma-move ni mother brought about by the anesthesia? Yes or no?
Yes po.
Yeah, so what will be the role of the nurse? So basically, the role of the nurse is to promote yung mobility ng lower extremities. Tapos, as expected, for 2 hours, at least si mother na ay nagtitake side, si mother na ay nag-ambulate, nakaupo na, nagdadangle na ng feet, kasi that's part of the early ambulation. Kailangan niya nang mangyari yon kasi for sure, within the 2 hours after the delivery, nag-subside na yung effect ng anesthesia. Okay. So dapat mag-ambulate siya to promote circulation. So, any question about analgesia, sedation, and anesthesia? So I think I have a question. Okay. Din hindi daw po, ay okay, sige po. Kala ko po hindi po makakabalik yung anesthesia. So sige, I was not just notified. Okay, next po. Yan. O, so ngayon pupunta na tayo sa medyo mga drugs na. So, now, when we talk about pain control during labor, meron tayong tinatawag na sedative tranquilizer, tranquilizer drug. Sedative tranquilizer. Natatandaan, pag nakakadinig kayo nito, sometimes when you watch movies, give tranquilizer, what comes to your mind? Pampakalma. Very good. Very good. Usually, tranquilizers are given because it has anti-anxiety effect. So, may sedative effect na siya. May sedative effect siya, tapos nagpapakalma pa. So, that's the sedative tranquilizer. Usually, these are given on the most commonly given itong sedative tranquilizer sa mga false or latent labor, or usually yung nagra-rupture na yung membranes niya without true labor. So eventually, ano yung sinasabi nating latent labor? Yung latent labor ba, yan ba yung early phase o yung late phase? Ang latent phase.
Early phase.
Early po.
Yeah, correct. So nasa early phase yan, pero ang pain niya pang pang late phase na ng labor. Starting pa lang siya pero pang late phase na. Tapos at the same time, nandun pa yung sakit-sakit na, ayoko na. You can observe and even identify yung mga first time, lalo na yung mga first time na nag-labor, sasabihin nila, ay, ayoko na ng ganito, mamamatay na nga, hindi ko na mauulan, ayoko na magbuntis. Tapos after 9 months, nakita mo na naman siya. Nandun na, oh mami, nadinig ko yan ako yung witness mo. I am your witness na hindi, sabi mo sa husband mo, hindi ka na magbubuntis. Eto na naman, buntis ka na naman for the second child. So yan yung mga situations na yung high, yung nasa ano pa lang siya, yung nasa early phase pa lang siya ng labor, habang nakikita niya yung husband niya. Kaya minsan yung mga husband, father, medyo stay ka muna sa labas. Kasi habang nagle-labor si mother, hanggat nakikita niya si father, nag-e-emote, ang sakit, ayoko na, ang sakit. Pag wala naman yung father, natutulog. So nakikita mo, na-observe mo. As much as possible, initially, you may not give sedative tranquilizer. But for situations like na ma-observe mo na okay, medyo hostile na siya, violent na yung kanyang behavior, ay magbibigay na yan ng sedative tranquilizer. Pero, remember, category D. So, anong category D? The mother could be affected. The mother could take the benefit na makalma siya, could take the benefit that she will be sedated, but what will happen to the baby? So the baby is also, can you imagine, the baby is also inside the uterus and also sedated. Kung sedated si mother, sedated din si baby. And what is the problem? If the baby is sedated also, you need to monitor the fetal heart rate. Kasi pag bumababa ang fetal heart rate, that's an indicative or that's an indication that there's fetal fetal distress din 'yon. Kasi bumababa ang heart rate. So, eto na po. Usually the drugs that may be given, ito ay isa secobarbital. So later on, if you will notice sa mga succeeding slides natin, may mga barbital diyan. Okay, yung mga barbital na yan ay usually these are mga sedative tranquilizers and used to decrease anxiety during latent phase of labor. Pero eto this drug are being given to the client, but it may not affect the uterine contractility. It can still progress the labor even giving this drug. But however, you must take into consideration that the category of the drug is D. So put it in your mind of the pregnancy risk category. Next po, pentobarbital. Okay, pentobarbital. So barbital pa rin. So sedative tranquilizer. So nasa isip niyo yan. So pentobarbital is also category D. So again, category D. So ang problem lang dito sa pentobarbital is short acting ang barbiturates. So ibig sabihin yung pinaka anti-anxiety effect niya, short acting, tapos yung sedation niya in management phase are short. So ibig sabihin, ito yung mga if the pain management can be tolerated by the patient one time that the drug will be given, the drug of choice is pentobarbital compared to the secobarbital. Kasi pag secobarbital, mas mahaba yung effect. Unlike for the pentobarbital, mas short acting lang siya. And if the mother can tolerate naman yung pain management and anxiety at the same time. Next po, another drug that may be given are promethazine. Okay. So ano po tong promethazine? So yan na naman si nandiyan na naman si antihistamine at saka si antiemetics. If we say antihistamine, antiemetics, this kasi remember 'di ba ang anxiety sometimes nagko-cause yan ng nagiging nauseated kasi alam natin that the gastric pH is increased during pregnancy. So sometimes nagko-cause yan ng added added problem for a person who is in labor dahil yung anxiety niya sumasabay during the situations. Remember 'di ba ang histamine 1, pag yan ay ni-stimulate, alam natin na magkakaroon ng minor discomfort yan. Yung somehow yung effect niya sa nausea and vomiting. So usually this drug could be given this be given intramuscularly. Are you familiar with Z-track method? Was this introduced to you? The Z-track? Not yet. Class?
Not yet po.
Not yet. O sige. Yung Z-track method, hindi yan yung needle mo, i-ZZ mo, hindi. The Z-track method, probably I may not demonstrate it here, but the Z-track method is you will instead pag intramuscular kasi, you will have the direct administration of the drug. So muscle. Pag Z-track method, ang Z-track method, you will retract the muscle. If you will retract the muscle, so i-change mo yung position ng muscle, then administer. So pag bumalik siya dun sa normal location ng muscle, malalock 'yon sa lower part of the muscle so that it may cause unilateral absorption. So the Z-track method may prevent. This usually may prevent severe tissue damage because it may not anymore cause for a while. It may not cause anymore just stay there. Recitation will be later. Okay, it will cause the possibility that if even given intramuscularly, the drug may spread throughout the tissues. Unlike for Z-track method, it will lock. It will lock from the site of administration until it will cause one direction absorption. So that, remember class, this is one of the examination that appeared in the 2017 board exam, that when you are giving intramuscular promethazine, what is the hindi pala binanggit yung intramuscular, when you're administering injection of the promethazine, injection of promethazine, what could be the administration? So it could be intramuscular, Z-track method, subcutaneous. So probably the answer is obviously the Z-track method. Okay, Z-track method. Sir, why is it indicated there? Z-track method for intramuscular. For a while. Okay, for intramuscular, it's because it will still reach the muscle. The difference lang is you will retract the muscle. You will have the change in position of the muscle, then inject, then bibitawan mo yung muscle, then continue to administer the drug. So pag bumalik yung normal position of the muscle, it will lock already the drug that you have administered. Okay, for a while. May question? Din yung Z-track method po ba is parang press pataas? Yeah, exactly. The you will retract the muscle up, but there is some instances that you will retract it on the side. Pero it could be retract up. Pag ni-retract mo yun up, hinold mo up tapos administer. Pag in-administer mo, bigay, labas tapos balik. So can you imagine once it goes back to its original location, na-lock na yon, kaya nag-Z. Okay? Na-lock na yung mismong drug that must be administered. Okay? So next drug, we have, ayan, hydroxyzine. Okay. The hydroxyzine are drugs which eventually, for a while, I will give you sedation, ha? Okay, now, what do you want? Sedation or anesthesia? Okay. Magnesium sulfate. Okay, I cannot assess your deep tendon reflexes. Now, when it comes to hydroxyzine and difference with hydroxyzine and difference with promethazine, also the drugs are ending in zine. Usually, hydroxyzine are anxiolytic antiemetic. So pag class, remember ha, if you have antiemetic drugs, kasi emesis is vomiting, so antiemetic is it will prevent vomiting. Kasi class, usually the anxiety level during labor also, as what I have mentioned, increases at the same time the hydrochloric acid while on experiencing anxiety. So that's why in this situation, hydroxyzine may have anxiolytic antiemetic effect. So on this situation, the concern is we have category C, and ang concern natin with category C, it may have an effect to the fetus. So again, let's have a review. Let's have a review for a while. We have a review for a while. Dogs. Later. Multiple choice questions will be raised later. Now, we have the secobarbital. These are anxiety, for a while. We have the secobarbital, decreased anxiety during the latent phase of labor. Then the next is we have the pentobarbital, which is eventually the difference with the secobarbital is that of it has a sedative effect, it has anti-anxiety effect, but short acting. So that's the difference. If it will be asked in the board exam. So what's the difference between secobarbital and pentobarbital? So obviously the pentobarbital has short acting drug, short acting. Okay. Next, what's the difference naman between promethazine and we have the difference between the hydroxyzine. So ang promethazine po, ang the highlight concept dito is it will be given intramuscular on a Z-track method. So next is we have hydroxyzine is both anxiolytic and antiemetic drug. So di ba remember class, the one that also triggers the vomiting is because of the histamine 1 during the early phase of pregnancy. So these are the sedative tranquilizer. Now, let us now proceed to ito mga higher level na to ha. Mga higher level, mga narcotic agonist. Okay. If we say narcotic agonist, ito na yung drugs that manages mild to moderate or moderate to severe pain. Na ang concern dito, the drug may have a direct effect to the pain receptors of the brain. Now, what are those drugs? So usually ito, mga narcotic agonists ay mga opioid. Okay. Ngayon, kaya siya, most of the opioid analgesics, remember this if it will be asked in the board exam, most of the opioids for pregnant categories are category C because of studies that may affect the fetus. Okay? But although the intention of the mild to moderate pain is hindi naman sa baby, the intention of giving this narcotic agonist is for the mother. So it so happen lang that it will benefit the mother, but it may cause an effect to the baby. So what are those drugs? Those drugs ay fentanyl citrate. These are opiate. Kung magkakaano mo yan, fentanyl citrate, morphine sulfate. O magkakaano yan. Usually may 8 sa huli. Fentanyl citrate, morphine sulfate. So for fentanyl, eto, remember, I don't know if you can still remember the time that we are discussing buccal. Yung sa buccal, yung drug na mention ko sa inyo doon, ang sample ko doon, fentanyl. When given buccal, usually for cancer pain. So ito naman, almost the same action pa rin naman ito is for pain, but moreover, these are usually given intravenously. Now, there's a concern. Always remember the highlights na ina-underline ko, because these usually are being asked in the board exam. If the client is taking fentanyl, it's usually contraindicated with severe asthma. Why kaya? Why kaya why kaya it's contraindicated with severe asthma? Kasi usually the effect of the bronchi sa bronchi when it comes to the most of the narcotic agonists ay parasympathetic. So, di ba nagko-cause siya ng constriction of the bronchi? So, how about if magkaroon pa siya ng asthma attack? Is it possible that it may further aggravate yung lalong constriction at severe attack of asthma? Yes or no?
Yes po.
Yes. Kaya that's why when you are giving narcotic agonist, always ask the client if she has she has history of COPD or asthma. Because furthermore, fentanyl citrate may not be or is not indicated for her if she has severe asthma. Now, how about morphine sulfate? Kung ang magnesium sulfate class is used to manage severe preeclampsia, ang morphine sulfate is usually is given as an opioid analgesic pre-operative medication. So what do you mean by pre-operative? Obviously prior to operation. Now, ang effect din ng morphine sulfate if it leads to toxic level ay the same as with the magnesium sulfate na class, it will lead to maternal respiratory depression and cardiac arrest din, because most of the opioids, sabi ko nga sa inyo, is sympathomimetic ang response. Ngayon, I even mentioned the antidote, di ba? If there's a problem with respiratory depression, that's obviously naloxone hydrochloride. And for the cardiac arrest or cardiac depression or suppression, the antidote is?
Epinephrine.
Very good, epinephrine. Okay. Next po. May mga drugs, there are some drugs naman na somehow may effect siya, it has an effect of both narcotic agonist, antagonist. What does it mean? Agonist, antagonist. So mix? Okay. How is it? Usually, these drugs are given to clients. Usually, pag sinabi nating mixed opioid, pag nandyan yung agonist at antagonist, there is somehow a balance to prevent toxic level. Kaya that's why, during my time that I was assigned in the labor room, most of the drugs that are given pre-delivery or sedation, the one that is being given as sedative, are these mixed narcotic agonist, antagonist, the nalbuphine hydrochloride. If you will encounter a brand name of Dubain, nalbuphine hydrochloride, these are mixed opioid agonists and antagonists. Usually these are given for clients who will be subject for normal spontaneous delivery as a choice for the sedation, because safe because it may not reach the toxic level kasi binabalance nga niya yung agonist and antagonist response. So we have two, butorphanol tartarate used in pregnancy. So class, meron tayo dito na this is used only for pregnancies higher than 37 weeks with no fetal distress. Pag may fetal distress, 37 weeks and above, fetal distress, do not give the drug. Okay? Pag if you will read my slides and review my slides, please highlight those that is very important for you to remember whenever you will encounter situations of clients in labor. So nalbuphine hydrochloride usually is safer rather than the butorphanol. However, both may be withhold if there is fetal distress. So what is fetal distress? If there is too much increase in the heart rate or the heart rate goes a sudden drop. So yun. Kaya pwedeng these are mga contraindications din. Okay? Now, self-assessment exercises. After the self-assessment exercises, we'll have the break and continue with our discussion. So, a patient with severe preeclampsia is on magnesium sulfate. The laboratory report shows magnesium sulfate of 7 milliequivalent per liter. Which of these is the most appropriate initial intervention? Let's see. Continue to monitor the patient because this level is therapeutic. Contact the health provider and report the level. Next, prepare to administer 1 gram of calcium gluconate. Turn the patient on her left side and administer 10 liters of O2 by nasal cannula. So I think the first one who raised the hand is Miss Delarmente. Miss Kyla.
A po din, continue to monitor the patient because this level is therapeutic.
Very good. Kasi you have seen na most na ang mga toxic level na niya ay nasa more than 10 na. Diba? Diba pag more than 10, doon na nagkakos ng maternal respiratory depression. Pag cardiac arrest na yan, nasa 20 to 25 pataas na yung level. Right? So on this answer, so let's see if the answer is correct. The answer is definitely correct. Just continue to monitor the patient because the level is therapeutic. Because below the therapeutic level of magnesium sulfate is below 10. Below 10. So higher than 10, it's already toxic level. So you may not definitely have the letter B, the letter C, the letter D because these are the measures when the drug are already reaching its toxic level. Why? Kasi 'di ba pag you may give oxygen if it has already higher than 10 and meron ng maternal respiratory depression. Administer 1 gram of calcium gluconate if it already proven na yung 7 kasi is still acceptable as therapeutic. Contact the healthcare provider and report the level is not an independent function, so probably this may not be necessary because it's still on a normal and therapeutic level. Thank you. Next. The nurse assessing a patient in preterm labor who is receiving magnesium sulfate. What is the finding of most concern? Alarming. Lethargy, feeling of warmth, loss of patellar reflexes. Letter D, positive clonus plus 2 bilaterally. Oh, Miss Cipriano.
C po, loss of patellar reflexes.
Let's see if your answer is correct. Answer is correct. Why? Kasi class, remember, every time that I always emphasize to you in giving magnesium sulfate, always remember to assess deep tendon reflexes. And if there will be no response of deep tendon reflexes, sir, wala naman dyan deep tendon na. Patellar reflexes po yon. So if it is patellar reflexes and loss of patellar reflexes, withhold the drug. The positive clonus and positive 2 bilaterally may not be significant when it comes to the findings of withholding magnesium sulfate. The feeling of warmth is normal because class, usually nga ang magnesium sulfate, ano yan? Very strong drug that will cause inflammatory conditions of the blood vessel. Malalaman mo yan, mainit sa blood vessel pagka in-administer. The lethargy is a change in the consciousness kasi nga 'di ba may sedative effect siya. So magche-change talaga yung from the alert somehow may have the side effect of drowsiness. So but that continuous lethargy is an indicative then na pagka nagtuloy-tuloy naman yan, that's very alarming. But most ang pinaka-alarming dito is letter C because once you give the drug and there's loss of patellar reflexes, the client will have risk of paralysis. Next question. The patient has been receiving magnesium sulfate IV for 24 hours to treat severe preeclampsia. On assessment, the nurse finds temperature of 37.3, pulse of 88, respiration at 14, blood pressure of 138/76, 21 patellar reflexes, and negative ankle clonus. What is the priority nursing intervention? Obtain a stat magnesium sulfate level. B. Discontinue magnesium sulfate. Letter D. Contact the health provider. And letter D. Continue to monitor the patient. Okay, so I think Mr. Ruiz Manuel?
Letter D po.
Letter
D.
B or D? Boy?
Dog po, dog.
Dog. So let's see. Let's see if that is correct. Tingnan natin. Oh, why? Why just continue to monitor the patient? Remember, looking at the vital signs, okay, looking at the vital signs, di ba, sabi ko, ano yung sabi ko sa inyo pag severe preeclampsia? Di ba ang severe preeclampsia is 160, above 160, 110? Severe preeclampsia siya. So, ibig sabihin, nag-improve. Nag-improve. So, another, di ba pag preeclampsia din, pag preeclampsia, ang preeclampsia din na mild is more than 140 ang systole at more than 90 ang diastole. So it seems the blood pressure is out of preeclampsia. So normal, right? So that's why there is patellar reflexes and ankle clonus is not expected. So it may not obtain stat magnesium sulfate. It may not discontinue magnesium sulfate because it's given as necessary. It may not necessary to contact the health provider. Just monitor because almost all of the findings based from your assessment and observations are normal. So sometimes you need to consider lang yung focus nyo for every questions that you may have. Next question. A young adolescent gravida 1 para 0 is admitted to labor and delivery with preterm labor at 29 weeks gestation. Class, ano yung period that I have mentioned to you that the client is already on preterm labor? Ano yung how many weeks gestation?
Below 37.
Yeah, okay. Now, which nursing intervention should apply the nurse include? Okay, ha? Letter A. Administration of antenatal glucocorticoids. So antenatal glucocorticoids is somehow close to the giving corticosteroids. Next, liver function test, bed rest of the left lateral position, administration of bolus. If we say bolus, okay, administered right away intravenous fluids or a certain amount or volume will be given on a fast drift. Next, we have administration of tocolytics, and letter F, administration of antihypertensive. So I think the first one that raised hand is Ruiz again, Francisco. So which nursing intervention should the nurse include? Select all that apply.
ACDE.
ACDE. So probably you may consider administration of tocolytics, correct? Because somehow there is preterm labor, and obviously to control the preterm labor or the contraction is by tocolytics. So that's correct. So you have answered letter A also?
Opo.
Yeah, because you have mentioned we have mentioned, di ba, pagka if the client is subject na for delivery, kailangan the glucocorticoids or corticosteroids must be administered so that to increase surfactant of the lungs to keep the maturity or to promote maturity of the lungs of the fetus. And the other one is, that you have answered?
A, C, D, E po.
C. Okay. The letter C is bed rest kasi 'di ba eventually I have mentioned to you for someone who's having preterm labor may have bed rest, and the left lateral position is for purposes of promoting proper circulation. So let's see. So we have administration of antenatal glucocorticoids. You're correct. Next. Yeah. Next, we have bed rest on the left lateral position. Correct. Another, we have Sige, titignan natin kung Y letter D ha. And another is administration of tocolytics. So just what don't be disappointed. You just missed 1 point. However, the liver function test may not be applicable because somehow this may not be directly related to the situation, and it's not clearly stated in the situation that may need liver function test. Administration of antihypertensive may not apply simply because the client naman is not having gestational hypertension. So, sir, why is it that administration of bolus of intravenous fluids? This is to promote hydration. Kasi for preterm labor, since the mother is experiencing the contraction, the uterine contraction, the baby is also experiencing pressure, and usually chances that both mother and the fetus experience problem with dehydration. So because of hypermetabolic response of the body. So that's why the administration of initial bolus of intravenous fluids is for purposes of hydration. So remember that. But eventually you just miss 1 point, but majority you have correct answer. Okay, next question. Okay, so probably before we proceed with the drugs for pain control, we may have a break. Okay, are you okay? There's a break for 10 minutes, so be back at 6:46. Okay, so very few na lang yung topic on this. Thank you. Okay, class? You're still here na? Are you
Yes.
still here? Are you here na? Mali pala yung question. Are you here na po?
Yes, Dean.
Okay, let's continue. Now we will be discussing about anesthesia. And let us now take into consideration that in anesthesia we are managing two types of pain during labor. We have visceral pain and we have the somatic pain. Okay. Usually the visceral pain occurs when there is contraction of the uterus and at the same time the start of opening and effacement of cervix. Because as what I have told you, it's always simultaneous. It must be simultaneous. The more that it progress the labor, the more that it is expected of regular uterine muscle contraction, simultaneously the opening of the cervix as effacement. That's the term. So the point that because of the sympathetic fibers affecting the muscle contraction, the strong muscle contraction, and the opening rather of the cervix, okay, of the cervix is called as visceral pain. And if we talk about when the baby is about to deliver and it will cause the stretching of the perineum. Okay, the perineum is the location of the perineum is from the mid portion between the rectal area and the vagina. So the stretching of the presenting part as well as with the vaginal canal, okay, is also affected by the stretching of the muscle fibers. That is somatic pain. So again, the visceral pain is brought about by the stretching of the cervix and the uterus, as simply as that. We are talking about somatic pain when it's already in the presenting part and it will already stretch the part of the perineum and the vagina, and that is somatic pain. And usually when there are some situations like that, the overstretching of the perineum, di ba there is some instances na yung overstretch of the perineum pwedeng mag-cause kasi yan ng tearing ng perineal tissues. Kaya that's why the obstetrician, when there is when delivery comes and yung presenting part are overstretched, lalo na kung yung baby ay large from the gestational age, pwedeng mag-tear yan. So pag nag-tear yan, pwedeng mag-cause ng bleeding. So what happens? The obstetrician may have the what we call episiotomy. Yung episiotomy is it will have an opening, okay, an extension of the opening so that it will not cause trauma to the perineal tissues. So on the other hand, that will also repair. Okay, so it will cause suturing, and the suturing is what we call episiotomy. So if we say episiotomy, rapi is referring to repair. Okay, so the one created is episiotomy so that it will not create trauma to the tissue during the overstretching of the perineal muscles and the vaginal muscles. So once it will be delivered to avoid trauma, then the one that had been created as episiotomy will lead to episiotomy. So those are situations wherein we are considering also local and regional anesthesia. So we have a consideration na pagka if it will create episiotomy, okay, episiotomy, that may use local anesthesia, and one of which is those drugs ending in cane. Pag regional block, okay, regional block, ito yung epidural or spinal anesthesia, it may not need anymore local anesthesia. Why? Because the anesthetic effect is from abdominal part below. So the loss of pain sensation are expected rather than only with local anesthetics. So if it's not painless, local anesthetics are given if it will create episiotomy. For the one who is requesting for the painless delivery, so that is saddle block, then you may use epidural or spinal anesthesia. So usually, there are some contraindications, okay? Contraindications of regional anesthesia. So yung spinal at saka yung epidural. Pag severe gestational hypertension or preeclampsia, it's definitely contraindicated. Why? Because somehow, since it has anesthetic effect and it may cause the direct effect to the spinal and somehow direct effect. What I mean direct effect, it may have a direct induction of anesthesia. So it may cause the numbness on the lower part. So eventually, this may trigger further hypertension because of the circulation aspect. So it's not advisable. So client, remember ha, pag hypertensive, gestational hypertension, no regional anesthesia. Next, pag may mga bleeding disorders, problem with coagulation, decreased platelet, which obviously if decreased platelet may lead to bleeding, don't give spinal or regional anesthesia because it may trigger further bleeding. Another is if there is generalized sepsis. Class sepsis is a term used for severe infection, or if there is a local infection at the site, yung needle site, yung spinal needle. So contraindications, regional anesthesia is not given. So these are the three regional contraindications of regional anesthesia. Now, these are the most common drugs or anesthetic used in obstetrics. So obviously mga cane, 'di ba? Mga cane ito. So if you will see, ang isa lang dito na ginagamit as safe for both mother and fetal is lidocaine injectable kasi local naman yung binibigay, local anesthesia siya. But the rest such as chlorprocaine, tetracaine, bupivacaine are category C because it may have the adverse reactions or possible adverse reactions sa fetus kasi usually ang chlorprocaine, tetracaine at bupivacaine are given lumbar, spinal, and the other one is epidural. So obviously anything that is given lumbar, spinal, epidural, magkukos yan ng direct effect to the circulation. Unlike for the lidocaine injectable, it's only localized. So lumbar, spinal, epidural are category C. It may cause adverse reactions to the fetus. So to prevent that, the nurse must monitor. So ang chlorprocaine are given lumbar, epidural, tetracaine is spinal, bupivacaine is epidural or spinal labor. Usually, 75% po ang bupivacaine not recommended because of statistics and findings ng cause ng cardiac arrest. Kasi remember pa rin na since it's lumbar and spinal, so it directly affects the nervous system. So baka it may possibly induce kasi parasympathetic responses at maglo-lower ng heart rate yan pag bupivacaine. So take into consideration among this anesthetic used in obstetrics. Okay, now let us now proceed to the drugs naman na will enhance muscle contraction. Actually, when could this happen? So syempre after delivery, it may not anymore contract. But it may still contract on an acceptable level kasi it must retain the abdominal or the uterine contraction. Pag nag-relax kasi ang uterine contraction niyan, pwedeng mag-lead sa bleeding. So that's why even after normal spontaneous vaginal delivery, there are drugs that are given as what we call uterotropic. So pag uterotropic, these are drugs that will enhance the uterine contractility. And why do we need to have uterine contractility? It's because it will prevent uterine atony. The uterine atony is relaxation of the uterus and chances may lead to bleeding. So, ang oxytocin po ay category C. Okay, category C may have adverse reaction sa baby. So, we need to monitor the fetal heart rate. So, usually ang oxytocin kung halimbawa in there's situations na ang labor hindi nagpo-progress. So, usually oxytocin are given so that it will progress yung labor. Next is these are given also postpartum, so after delivery, so that to prevent hemorrhage, and as what I have mentioned, to prevent continuous relaxation of the uterine muscle post-delivery, because somehow if the client may have uterine atony, it may lead to bleeding. So next, another kung if there are no oxytocin, there could be chances that the patient may have the metylar gonovine maliate. Sometimes these are having brand names of Metergine. Okay. Ang Metergine, this is prevention and treatment of postpartum hemorrhage, subinvolution, these are yung profuse bleeding, and post-abortion hemorrhage. So obviously it boils down to prevention of hemorrhage and prevention of the relaxation of the muscle, of uterine muscle. Usually, remember this, contraindicated ito with maternal sepsis or labor induction. This is not used usually as vasodepressor. Pag sinabi nating vasodepressors, this is not used to relax the blood vessel and allow specific circulation. So hindi yan binibigay with vasodepressors as well. So I think that ends up my topic for the midterm. Those drugs that are subject for the midterm coverage. So I will stop my sharing. And